The majority of patients with advanced cancer present with multiple symptoms, including loss of appetite, fatigue, loss of skeletal muscle mass, and loss of muscle strength. Taken together, these symptoms are quite devastating and frustrating to patients, families, and healthcare providers, and converge in a syndrome which does not have an FDA-approved, safe, and effective treatment. Cancer Anorexia-Cachexia syndrome, or CACS. Anorexia-Cachexia syndrome may present at different stages of the cancer journey, sometimes also at the time of diagnosis. Its prevalence becomes more pronounced as cancer progresses and increases up to 80% in advanced cancer patients. Consequences of this wasting disorder may result in a reduction of treatment tolerance, reduction of response to therapy, reduced quality of life with physical disability, shortened survival, and death. Cancer Anorexia-Cachexia syndrome is multifactorial, and it is caused by a combination of reduced food intake and abnormal metabolism, induced by tumor and host-derived factors. Inflammation drives the neuroendocrine response, associated with reduced appetite and anorexia. Inflammation also induces metabolic derangement, which can lead to loss of lean body mass and adipose tissue. This is independent of a patient's nutritional state and cannot be fully reversed by conventional nutritional support. The inflammation of cancer Anorexia-Cachexia is stimulated by tumor-derived factors as well as pro-inflammatory cytokines from both tumor and patient. Tumor necrosis factor alpha, interleukin-1 beta, interleukin-6, and interferon gamma all play an influential role in generating the systemic inflammatory response. In particular, interleukin-6 induces liver production of acute phase proteins, such as C-reactive protein, which drives a sustained or prolonged inflammatory state. The suppression of appetite and the early satiety may occur through persistent activation of the melanocortin system and inhibition of the feeding stimulatory neuropeptide Y pathway in the hypothalamus. Cytokines may also act in the hypothalamus by mimicking the peripheral adipose-derived hormone leptin, inducing anorexia and unopposed weight loss. Together, neuropeptides and cytokine interactions may mediate a reduction of the appropriate hypothalamic response to both peripheral metabolic signals and energy imbalance. Systemic inflammation may also be associated with metabolic derangement, the alteration of body composition characterized by hypermetabolism and loss of both lean body mass and adipose tissue. In muscle, multiple cytokines play a role in muscle atrophy, either through reduction of muscle synthesis or promotion of protein breakdown through activation of the ubiquitin proteasome pathway. Metabolic derangement is not limited to skeletal muscle in a cancer patient with Anorexia-Cachexia syndrome. Multiple factors, including reduced food intake, tumor factors, and inflammatory cytokines also promote adipose tissue wasting. Significant unmet needs remain in the recognition and management of the cancer Anorexia-Cachexia patient. There are no agreements upon successful nutritional interventions, and there are no FDA-approved, standard effective pharmacotherapeutic options to prevent or treat this disorder. Early recognition and ideal treatment management with a multimodal approach may embrace three overarching strategies: appetite stimulation, reduction of catabolic processes, and promotion of the muscle synthesis.